Good evening, everyone. My name is Dr. Manojit Sinha. I'm one of the I'm consultant in pain medicine from King's College Hospital. So today our webinar is on the pelvic pain management. We have very good speakers today. So let me introduce you to the first speaker. Is Prof. Ashish Shetty. He is a consultant lead and the neuromodulation lead from University College Hospitals, London. And his interest is mainly on pelvic pain and neuromodulation. He has done a lot of research and has done a lot of publications. He's faculty for many courses in this country and worldwide. After Dr. Shetty, Andrea Palko will present on MDT, multidisciplinary management of pelvic pain. She is working as a specialist endometriosis nurse at Princess Grace Hospital. She has worked with the pelvic pain team in University College Hospitals, London, and she is one of the trainer for the MSc module in pain management. I welcome both of them, and we can start. I'll start with Dr. Ash Shetty. He can start with his presentations. So if you have any questions for Dr. Shetty, so we will discuss all the questions after he finishes his presentation. So we have 10 to 15 minutes, 15 minutes to discuss any questions you have. And you can put your questions on the chat box. So I will pick up the question and we'll ask Dr. Shetty, Prof. Shetty, after finishing his presentation. Thank you.
Good evening, everyone. Thank you, Manojit and BPS for this opportunity to discuss pelvic pain. So I see that there are a lot of experienced pain physicians here. So I think we've grown out of the Zoom webinar. I had thought that we had come out of the Zoom webinar zone, but we continue to do webinars where I can't get any feedback from the audience. So before I start and I'm doing my disclosures and introduction, if you have questions, start typing them now in the next couple of minutes. And I'll try and tailor the talk to the questions that have been asked so that you get more out of this webinar rather than a didactic one-way talk. So in the middle of the talk, I'll quickly bounce back and Manojit can probably look at the questions and ask me in the middle. And so raise your hand and stop me if at any point you want to discuss further. So pelvic pain in general is thought to be a restricted area, and people have this impression that it's only practiced in a select few places. And it is not for the normal pain physicians. So these are my disclosures, a lot of educational disclosures and commercial disclosures, but hopefully I'll not be using any of these products during the talk. As a part of my role at the Royal Society of Medicine, we have a meeting coming up with an interesting perspective from the legal fraternity and the medical fraternity. And we have a session on pelvic pain, the complications from the incontinence mesh, which seems to be very popular at the moment. Some of the recently concluded cases, and a perspective from the uroneurogynecologists and peripheral nerve surgeons. So if you're interested in that sort of information, please look this up. It promises to be a great evening. So today's talk, it's limited to a 30-minute or a 25-minute talk on the role of interventions in managing pelvic pain. In terms of the interventions, we'll discuss the evidence, and after we've discussed the perspective from the management aspect. and maybe possible future direction of where it's going. So where we are based, we are at University College London Hospital, and we are a tertiary specialist center for pelvic pain management. We have been growing. When I joined the department, we are close to 50 odd members, and now we are over 100 members in the pain management team. We work with several specialists. We have joint clinics with urogynecologists, gynecologists. We have a specialist endometriosis center where pain physicians are part of. I have a joint clinic with a neurosurgeon, and there are neurologists within part of the pain clinic. Within the pain clinic, we have a specialist abdominal pelvic pain team. 6 of us run regular pelvic pain clinics, and the setup is quite important if you want to practice pelvic pain and provide a holistic care. We have specialist nurses, with pelvic pain physiotherapists, 4 psychologists who specialize in pelvic pain. It's taken several years to develop, and this was all set up for me, so I didn't develop this. So I'm sorry for putting this up, but this is the recently published report where the hospitals are ranked, and the specialist hospitals we sit under the neurosciences department, and it's nice to see that we are in the top 3 hospitals in the world. In terms of the problem itself, why are we all today? Why is there so much interest in pelvic pain? And rightly so. If you look at the prevalence of pelvic pain, compare that with asthma. Asthma is 37 per 1,000, and back pain is 41 per 1,000. And the pelvic pain prevalence is more than asthma and comparable to that of chronic back pain. And yet, there are so few of us who have a specialist interest in pelvic pain management, and we work in silos, whereas conditions like asthma and back pain, everyone is interested in managing that condition. If you look at women attending pain clinics, it's the commonest problem in 15 to 20% of women aged between 15 to 73 years, and they have pain lasting for about 1 year. Is a primary indication for about 1 in 5 gynecologic visits. 1 in 10 hysterectomies are done for pain alone, and 40% of diagnostic laparoscopies are done to investigate chronic pelvic pain conditions. The burden to the society is huge in terms of the need for medical treatment, for surgeries. The amount of money spent in US is close to 880 million. The pursuit of treatment of pelvic pain starts with identifying the underlying cause, and they're gender specific. In women, there are conditions, and we often label this as chronic pelvic pain syndrome, which doesn't really mean much. So if you can narrow it down to, is it related to endometriosis? Is this pain? And it's not giving a specific diagnosis, but at least we know what we're talking about. The cystitis interstitial cystitis is no more a term that's used in pain clinics. It's more of a bladder pain syndrome. There's vulvodynia, and look out for primary causes that can be treated. And if there is persistent pain after treatment of primary causes such as endometriosis or cancer pain. In men, most often it is the bladder or the prostate that is labeled. Again, you can, when you're looking for pathologies, it can be organ specific, and it depends on the specialist the patient goes to. You can have referrals from the gynecologist, the urologist, colorectal surgeon, even neurologist and the urologist. To simplify the etiology, I created this slide, and it was quite an eye-opener for me, because most of the sufferers with pelvic pain, if you are a female, you go to a gynecologist. If you're a man, you go to urologist, but they're not the commonest cause. The commonest cause of pelvic pain is often the GIT. Um, then is urology, and then musculoskeletal, and gynecology comes a fourth common cause of pelvic pain. In fact, in 50% of the patients with chronic pelvic pain, there might be more than one cause uh, of their condition. And of course, the one thing that unites them all is the psychological overlay and the emotional makeup of the patient and their ability to cope with the pain. So get to structures outside the uterus. Is not all just like in headaches. Is not every headache is migraine or trigeminal neuralgia. Not every pelvic pain is endometriosis. If there's a single most important slide for this evening, it is this one, and you can forget the rest. So the visceral structures, the bowel, bladder, uterus, and the somatic structures, the muscle, bone, skin, they share a common neural pathway, and we all know this. But when assessing, we tend to focus on either a musculoskeletal pain and keep doing those trigger point injections, or we keep blaming the pudendal nerve, and we just focus on one condition. So the visceral and the somatic structure, share the neural pathways, and these neural pathways interact with each other. So pain that seemingly appears to originate from a visceral structure might actually be a somatic pain, and vice versa. And this phenomena where sensations coming from the visceral structures amplify the pain originating in the somatic structure is called as visceral cross sensitization. And when the somatic movements make the visceral pain worse, it's called the viscerosomatic sensitization. So you might have that patient, for example, if you look at SI joint pain, you might feel that, okay, this pain is sounding like a pain originating from this joint, and you do the diagnostic block, it doesn't work. And you feel that the somatic structures are responsible, but are not responding to that intervention. Again, it could be a inguinal pain where the patient points out to this sudden point in the body and says, I'm pretty sure there is something underneath there. Cut me open, block that nerve, and you keep doing that and without success. So keep your mind open for this phenomena where the visceral and somatic structures sensitize each other. To simplify all the previous slides, when you're looking at a pain condition that's originating from pelvis, try to put it in one of these boxes. Is it a visceral pain? Is it a musculoskeletal pain? Is it a neuropathic pain? And most importantly, could this be a pain of central origin? Important to understand anatomy again. The boundaries of pelvis are not well defined from the pain management perspective. There is a true pelvis and there's a false pelvis. But if you look at the whole cavity, the pelvic cavity, the abdominal cavity, the anti-abdominal wall, and the spine, they're all connected. If you're sitting there, just try taking a deep breath in and hold your breath, and you will see that you need to contract your diaphragm, your abdominal muscles are contracted, your pelvic floor is contracted. And so a activity in one structure can influence activity in other structures, and hence the challenge of pelvic pain. I put this here. This is mainly relevant from the intervention perspective. For those of you who do interventions in the lower lumbar spine and the pelvic region, you'll find that interventions are the challenges are different in a male compared to female. Again, within the sex, there can be challenges. You might have to tilt your C-arm differently. You might have to use your ultrasound differently. And that is because everyone has a different shape of their pelvis. The angulation between the pelvic outlet and the spine can be different. So you might have to have more steep angulation, cranial tilt when you're doing your injections in the pelvis, including sacral nerve root injections, SI joint injections, pudendal nerve, piriformis muscle injections. So you need to be aware of the sexual differences, and within uh, uh, be aware of the different shapes of the pelvis. Apart from the bony differences, the musculoskeletal differences, if you move on to the neural structure, the sclerotomal distribution and the dermatomal distribution in the pelvis is not very intuitive. And there are multiple nerves overlapping within a small area in the pelvis. And the pelvis has got innervation from the lumbar plexus, the lumbosacral plexus. There are quite a few structures there, and I'm not going to bore you with each nerve because you're familiar with that. But just the groin alone, if you look up there, we often get patients referred to a center where they say, oh, this patient with pudendal neuropathy, can you do a pudendal nerve block? And if we ask them to shade the area of their pain, it is usually ilioinguinal, genitofemoral, or iliohypogastric even sometimes. If you plot these nerves with their spinal segments, you'll see that a pain affecting the testicular region could be originating either from T12, L1, L2 via ilioinguinal, iliohypogastric, and genitofemoral nerve, or coming from even the sacral nerve roots in terms of the innervation via the pudendal nerve. So, and they're far apart, T12 to S234. And we might just be fixated on one or the other. So if you draw the diagram here, unlike the upper limb or the lower limb where you can measure, I mean, you got C6, C7, T1 innervation in the upper limb, C5 in the shoulder. In the lower limb, you got L1, L2, L3, knee, and then in the middle aspect is L4, lateral aspect is L5. In the pelvis, you can see the L1 stops, and then you got a S3, S2, and so they're closely linked, and they were not very intuitive. So watch out for the area of the pain. There's often an overlap, and have a plan to test other nerve roots as well, rather than just blocking a single nerve. In addition to these nerves, there is sympathetic and parasympathetic innervation, the structures of ganglion impar, the sacral splanchnic nerves, the pelvic splanchnic nerves, the hypogastric plexus, all play an important role in maintenance and propagation of chronic pain condition. The pelvic ligaments themselves are far too complex, and when we are looking at pain originating, say, from the SI joint, we are not able to get to all these anterior ligaments that could be involved in contributing to pain. For completeness sake, this is the blood supply of the pelvis. And in terms of today's talk, let's focus on some of the interventions. This is not extensive, but this is the menu of the interventions that you could consider when managing pelvic pain. The simplest of them all is ganglion impar block, and the safest. And probably at the extreme end is the hypogastric plexus block, the superior, middle, inferior hypogastric. You can target the hypogastric via ganglion impar itself. A huge volume often blocks the lower hypogastric plexus. Otherwise, the block at L5 is probably a bit more complex. Then you got the lumbosacral plexus, and there you have the pudendal nerve, the ilioinguinal, iliohypogastric, genitofemoral, obturator, femoral cutaneous nerve, and the posterior femoral cutaneous nerve of the thigh. Of course, trigger point injections is commonly performed. Use of Botox is not that common in pain clinics, but there is a role for it. I personally prefer nerve root blocks to test the source of the pain and the pain generators. And my special interest is neuromodulation, and that is more therapeutic in my opinion. And the former, the blocks are diagnostic in nature. You can try lidocaine infusions and ketamine infusions and magnesium in suitable patients. The evidence base itself is weak. Looking at each block by themselves, in the last 10 minutes, we'll cover these. The ganglion empire block, the ganglion empire is a set of structures sitting in front of the sacrococcygeal junction. It has sympathetic afferents from the distal rectum, the anus, urethra, vulva, and the distal third of the vagina. Injection is done generally with fluoroscopy, as you need to see the contrast spread and avoid the bowel there. The most common approach is transsacrococcygeal. If you are an experienced operator, you can try other approaches if this route is closed or ossified. The block is usually done with local anesthetic and steroid. In cancer pain patients, phenol or radiofrequency ablation can be tried. The block was originally described by Plancart from South America, and he's described 3 or 4 different blocks. And I had the honor of and privilege of meeting him recently. He described this block first in the early 90s in patients with advanced cancer pain and perineal pain. He used phenol, and he reported that all the patients had good outcome. They were followed until they died, and the duration of follow-up was about 120 days in patients with terminal cancer, but majority of them had significant reduction in their perineal pain conditions. The further study by Swofford et al., similar group, but here they use bupivacaine and steroids in 20 patients, and 18 of them just needed local anesthetic and steroid, with 5 of them reporting 100% pain relief, 10 over 75% pain relief. In 2 of those patients, they had to use phenol because the pain was short lasting. And there've been publications for use in non-cancer pain, but small number of patients. When I started off managing pelvic pain, I tried to replicate these studies using the same numbers and in pelvic pain patients. And we did a prospective study, follow-up of patients who were listed for ganglion empire blocks. So these were not carefully selected patients. These were patients who were listed, and we were able to get similar outcomes in our patients. So in 14 patients with various variety of diagnosis, we had patients who reported a significant reduction in pain, improvement in sleep, bowel, bladder, sexual function, improvement mood, and even return to employment. It's a fairly safe block if you have the necessary training. There's a theoretical risk of injury to the bowel. Generally, it goes unnoticed, but the fecal contamination can result in discitis. In a recent Google group discussion, there was a mention of osteomyelitis following ganglion empire block. So watch out for the complications. If you recognize it early, a simple course of antibiotics might help you. In terms of other blocks, superior hypogastric block is not performed as often as it should be. It has got far bigger afferent drainage region compared to ganglion empire. It gets afferents from the bladder, urethra, the vagina, vulva, perineum, rectum, and colon. The procedure, I personally prefer the posterior approach at the level of L5. Technically challenging, you need a longer needle to reach in front of L5 as iliac bone is in the way. The other approaches are anterior intradiscal, which I avoid generally unless it's technically challenging. It's a bilateral procedure, and the contrast has to spread anterior to the L5 vertebra. Evidence base, again, this block was described by Plancart in the 90s for patients with pelvic cancer, and he reported 70% mean reduction in pain. They were followed until they died. A further study was done in 1993. There's been RCTs and large-scale studies. This group of 227 patients had bilateral superior hypogastric plexus block, and there was a significant reduction in pain scores. We've got 3 minutes, so I'll rush through this. Um, you always ask for evidence, so there is RCT with huge number of patients. There is evidence of neurolysis working in non-cancer pain. I personally do not destroy anything in non-cancer pain patients. Again, we did a prospective uh, review of patients having superior hypogastric plexus block, and we had similar reduction in VAS scores and duration of pain relief from superior hypogastric plexus block. This is a block with slightly higher complications because you can damage the L5 nerve root, the bowels, and also cause discitis. So this needs fair bit of training compared to the ganglion power block. I won't spend too much time on pudendal nerve block because this is the commonest block performed and almost everyone is able to do this. But it is, however, it's not done properly. The nerve itself is a mixed sensory motor and autonomic nerve. It can be injured during prolonged lithotomy. So if the patient has a history of being in lithotomy position while undergoing gynecological or colorectal procedures, have a high suspicion for this injury. In the mesh or the incontinence patients or sacrospinous fixation, the surgeons take a stitch few centimeters from the ischial spine where the anatomical variation of the nerve makes it prone to nerve injury. So history of sacrospinous fixation resulting in rectal pain or perineal pain should give you a possible suspicion of involvement of the nerve. The biggest role is in diagnosis of pudendal neuropathy, and there's a NANS criteria, and one of the diagnostic criteria is the block giving pain relief. Again, we looked at a big group of our patients having pudendal nerve block. Overall, the evidence for pudendal nerve block as a therapeutic procedure is very low. In terms of a diagnostic block, it is an important block to be aware of. Now, quickly, the musculoskeletal pain, myofascial pain syndrome. There's a lot more to pelvic myofascial syndrome than the piriformis muscle. The deep gluteal syndrome, there are a lot of other muscles involved. Botox injection has been compared with saline, and the outcome is very similar. Okay, to close off, we need an algorithm, something like this, which has been described for coccydynia, where we do coccygeal nerve blocks followed by ganglion impar block. But in essence, pelvic pain is more complex, and you need to have a wider range of therapeutic options, where initially you have conventional management and conservative therapy, including physiotherapy, vulval care measures, biofeedback, and cognitive behavioral therapy. And then there is injections, radiofrequency procedures, and I would even put neurostimulation procedures if the neuromodulation, if the simple interventions don't work prior to the patient having non-reversible procedures such as hysterectomy. So we are done with time, so I will close here. All I would like to convey today is the role of interventions is huge in managing pelvic pain and should be combined with other modalities. The interventions have diagnostic and therapeutic role, and multimodal management is better than conventional management, a single management. Thank you. I'll take any questions if.
Yeah, thanks, Ash, for your presentation. So I have few questions from few of us attendees. So let's start with the ganglion of impar block. So Nofil has asked you, how much volume do you use for ganglion of impar block?
Okay, if you are a purist, you should not use more than 1 ml or 2 ml, but we are not. So we generally use 5 to 10 mils. And I think the outcome of my ganglion impar block is better because the local anesthetic spreads to the inferior hypogastric plexus. So I don't care because I would rather get a good outcome, and unless it's a study protocol. It's a combination of local anesthetic and steroids. It's safe to use particulate steroids with bupivacaine, and I tend to use anywhere between 5 to 10 mils.
Sure. And if you want to block the hypogastric plexus, can you do that by giving a bigger volume through ganglion of
Technically,
Impart?
yes, but it doesn't reach the superior hypogastric plexus, and fluid takes the path of resistance. So if you're doing a superior hypogastric plexus, you need to be at L5 level. Generally, the lower bit of the hypogastric, you can go through the sacral foramen, but you risk injuring the sacral nerve roots. So I tend to either do at L5 level for hypogastric and ganglion impart through the sacrococcygeal junction.
Okay. For hypogastric plexus, how much volume do you use?
Again, similar volumes. You got to be cautious at this level because it can spread up and can give you hypotension and so on. The volume is again it's a bilateral block, so I use 5 mil on each side.
Okay. And in terms of neurolysis through ganglion of Impar, or what do you prefer? Is it alcohol or phenol?
I generally don't do cancer pain management anymore, so I don't destroy this structure. But generally, it's phenol that I use.
Okay. Do you do any radiofrequency of ganglion of Impar?
It can be tried, but ganglion impart is not a single structure. It's a bit like stellate ganglion where there are multiple structures there. Maybe even more complex, and the path is not easy through sacrococcygeal. You got to go to parasacral approach. So in my hands, it has not worked that well. Doesn't mean you can't try it.
Sure. There was another query from an attendee, anonymous attendee, and they have asked us, what is your experience with quadratus lumborum block in regards to pelvic pain? As you have mentioned before, there is a lot of viscerosomatic contribution to the pelvic pain. Does it, do you have any experience? Does it help with pelvic pain, as they have quite a good experience? Their local experience is very encouraging in regards to quadratus lumborum block.
Okay, so the evidence for quadratus lumborum block, or most of the regional, I think it's a block of regional anesthetists, and most people do it because they can and they have the expertise. Personally, I don't use the regional anesthesia blocks. If it is a diagnostic block, for me, the question is, what are we trying to do? Are you trying to just give pain relief for the duration of the block, and what are you trying to block here? So if your experience is good and you have published this, I would be grateful if you can send your papers. We don't use that much in terms of quadratus lumborum block for chronic pain management. If in our hospital, they do use the quadratus lumborum block probably for regional anesthesia in the regional anesthesia department. So I'm sorry, my experience is not that great.
Okay. Another question from Almas is regarding lidocaine or ketamine infusion. Do you offer to your patients regularly, or if not, at what point of time do you offer them?
I don't offer my patients lidocaine or ketamine.
Okay. And question from Dr. Ron Cooper. Do you find spinal cord stimulator helping patients with pelvic pain? Is there any value?
Absolutely. I think in a few selected patients, the outcome is fantastic. Having said that, it's not for everyone. The patient selection has to be is the most critical component, especially in terms of A, is it a focal neuropathic pain? B, are there significant yellow flags? So in a patient where A is not focal and B, there are a lot of yellow flags, stay away from neuromodulation. But if it is focal and where almost all patients have yellow flags, and that's okay. If they can be addressed, then that's okay. We've had some great results with neuromodulation. However, at the same time, the published literature shows that there is an explant rate of about 1 in 3 at the end of 2 years. There's almost a 50% explant at 3 to 4 years. And I think at 5 to 6 years, it's almost close to 100%. So you got to select your patients, otherwise the therapy gets a bad name.
Thank you. Another question is about coccydynia. Does coccyx injection work?
Yeah, so coccydynia, there's a evidence-based protocol. You do a coccygeal nerve block, and and then there is ganglion impart block. There are occasional, the evidence for coccygyectomy is 2B minus, so you can cause more harm. then good. But there is an odd patient that we always have who goes to France, gets coccygectomy done, and gets better. I've had two such patients in the last 10 years, but I've had probably about 10 to 15 patients who have developed neuropathic pain, severe coccydynia, following coccygectomy. So there is a protocol as a part of this talk, and I'm happy to share. Otherwise, if you just look up the evidence base for coccydynia, there's a nice algorithm for management of coccydynia.
Okay. So there is another question from Naomi. Would you do anything longer lasting at superior hypogastric plexus where short-lived but good response in benign pain, not for malignant patients?
So benign pain, my protocol would be I will do the block. I have one patient who I repeat the block every year because it gives such good pain relief that it helps him stay in employment. And that is only when I'll repeat. I don't do, I mean, I have tried PRF in odd patients, but if it has given good pain relief, then I proceed to neuromodulation in these patients. I don't tend to stick a needle at L5 level every few months. I think it's far too riskier compared to doing something, doing a trial of smart neuromodulation.
Another question is from Amit Kumar. So he has asked that a caudal epidural collects in front of the coccyx and often the sacrum. Why not consider it as a much safer procedure to ganglion of impart block?
Okay, a caudal, I mean, the two different blocks altogether. It's an epidural versus ganglion impart. So caudal epidural does not collect in front of the coccyx. It goes into the epidural space. And if you put a contrast next time and take a picture, you'll get an inverted or a Christmas tree appearance showing that the medication will go through the sacral nerve roots. So if you are struggling with pudendal nerve, maybe it's a good idea to do cox. And it's not a bad treatment if you can't do the pudendal nerve or selective nerve root block, because you'll block all the sacral nerves. So it's a non-specific block. If you want to give a momentary pain relief, it's not a bad idea. In a chronic pain clinic, the role is limited, but in a select patients where even coccydynia patients, you can give them temporary pain relief for the duration of local anesthetic. So two different blocks.
Two different blocks. Thank you. And this question from my side is, if we do a selective nerve root block, do you follow with a pulse radio frequency if it works well for the patient?
Yeah, always. And now because of waiting list, and there is a lot of argument in this field, and people say it's not pure PRF if you put stuff in. In select few patients who are traveling from abroad, including Northern Ireland or the Middle East or Scotland, I now tend, if I'm doing a selective nerve root block, say S1, S2, S3, I tend to stick a needle in, a PRF needle in, do the PRF and the block at the same time. Ideally, I don't like it. I like to do a diagnostic block followed by PRF at two different sittings. But if the wait is going to be a year and the patient is traveling 8 hours, then I just combine it to see if that gives them longer lasting pain relief.
Okay, so you've answered my next question, because there was a question from Jacek. Do you accept referrals of patients with pelvic pain from Northern Ireland? And what are the waiting times?
So the waiting times, we are in line with the national guidelines. So we probably for pelvic pain, we haven't paid a fine for a long time, because it's for pelvic pain patients, we tend to give a Rolls-Royce treatment at our center for whatever reason. Scotland, Northern Ireland, Wales, I think as long as there's a support from your local CCG, it should be done. Scotland is different compared to Northern Ireland. So if there is a support, then yes, I do have a lot of patients from Northern Ireland, very few Northern Ireland patients in the NHS. So that I think has to be checked with the local CCGs. But personally, happy if the letter comes to me, I'm happy to offer an appointment. The managers can sort out the paperwork.
Sure, thank you. Sorry, there's another question regarding pulsed RF just came now. Would you use any local anesthetic and steroid also when you are doing pulsed RF in a separate setting?
So I tend to do that. Like I said, there's a lot of argument, evidence of RF itself. And do you use, so when I do a pulsed RF, I stick a needle in, I do the RF first before I put anything. Otherwise it changes the nature of the RF itself. After the RF, I do block it, but there's been arguments for and against putting stuff after you've done RF, because RF is designed to change the neurobiochemical nature of the inflammatory mediators around the nerve, and by blocking it, you change that nature. But the evidence for RF itself, pulse RF itself, is weak. There is argument about the duration of the RF, the stuff that to be used. My personal preference is I do a pulse RF for 6 minutes, followed by local anesthetic and steroids where I can.
Okay. So there's a question which is not regarding intervention. That is, during chemotherapy, is a sodium channel blocking drugs help more than gabapentoids? There's a question from Almas.
Okay, so cancer pain is a minefield, and I've got out of this because generally the treatment in cancer patients, in terms of the oncologist, is they treat cancer pain with more chemo and radiotherapy. And so it's very hard to work with palliative care physicians. They would rather give opioids. So there is no studies to show one is better than the other. And in terms of pain management, sodium channel blockers, I think personally they help better with acute pain, in acute pain settings or acute exacerbations of chronic pain. In longer, the chronic, constant chronic pain, probably anti-neuropathic pain medications work better, but I might be wrong in it. I'm not a cancer pain specialist. Probably our BPS president, Arun Bhaskar, will be a better person to answer that question.
That's true. Last question for you, Ash. Which steroids do you prefer? Do you prefer Canalog or dexamethasone, or particulate or non-particulate for your injection?
So, I mean, there's a guidance on use of particulate, non-particulate steroids, but for ganglion impaired, hypogastric plexus, and even pudendal nerve, I tend to use depomedrone because it's been my practice. For anything that's epidural or nerve root, sacral, I use non-particulate such as dexamethasone. And again, we haven't had problem. I've been doing it for over 10 years now, but I follow the guidelines for the particulate, non-particulate when it comes to nerve root, neck injections, and epidural. There's a question regarding neuromodulation modality for pelvic pain. It says a lot of data with SNS. So the data for SNS is very poor. SNS does not have an FDA approval for pain. It has for bladder symptoms. So urologists do a lot of it. For pain, SNS, there's almost 100% explant rate at 5 years. So I feel there is a better outcome with SCS. We in our own center will be shortly publishing our long-term data, hopefully with SNS, because we have hundreds of patients who've had SNS. SCS, there are fewer patients, but I feel the outcome is better. So Mohammed Yunus Kilji has asked that question, and I'm happy to discuss with you on one-to-one basis if you have questions.
Thanks, Prof. Shetty, for your presentation. It was a very nice and comprehensive presentation. I hope that it has helped everyone present here. So I will go to the next presentation. So for the next presentation, we have Andrea Palku. She's a specialist endometriosis nurse. She works at Princess Grace Hospital, and she has worked at UCL pelvic pain team, where she is also one of the, she covers one of the module for the MSc pain management at UCL. Over to Andrea, please.
Thank you. Good evening, everyone. Thank you for having me here presenting. I'm trying to share my desktop right now. Just 1 second. Can everyone see it? Yeah, okay. So in the next 25 minutes, we're going to explore multidisciplinary approach to the chronic pelvic pain management. The objectives of this presentation will be to discuss about pelvic pain prevalence, the challenges of the pelvic pain management, and the importance of a multidisciplinary team approach, as well as briefly discussing about integrative approaches to pain management and how to manage to have an effective multidisciplinary pain management team. So pelvic pain is a common problem that affects both men and women of all ages. It is usually caused by a combination of physical, psychological, and social factors, rather than just one single condition, and can range in severity from mild to severe pain. Pelvic pain can be debilitating. It's a debilitating condition that negatively impacts person's quality of life. It is estimated that between 14 to 24% of women experience chronic pelvic pain at some point in their lives. And approximately 40% of these women with pelvic pain actually have symptoms lasting longer than 6 months. Moreover, it is estimated that 1 in 7 men in the UK will also experience pelvic pain at some point in their lives. Chronic pelvic pain can be very difficult to live with and can cause emotional difficulties, social difficulties, and economic difficulties. It can cause emotional distress like anxiety, depression, feelings of isolation. Patients may experience frustration and hopelessness due to the chronic nature of their pain. Also, they can have associated challenges with managing it. All in all, this can lead to decreased quality of life and increased risk of mental health disorders. Patients may have difficulty participating in social activities due to their pain, or sometimes they may feel embarrassed or ashamed about discussing their condition with others. And this can also lead to social isolation and decreased sense of connection with others. The economic consequences of chronic pelvic pain can stem from the fact that patients may miss work or may have decreased productivity due to their pain. This in turn can lead to financial difficulties. And on top of this, sometimes treatments for chronic pelvic pain can be costly, particularly if they involve surgery or long-term medication use. So chronic pelvic pain can have a significant impact on a patient's quality of life and well-being. And it is important for healthcare providers to address not only the physical symptoms of the condition, but also the emotional and social and economic difficulties that these patients may face. This may involve a multidisciplinary approach that includes mental health professionals, patient educators, and other specialists who can actually work together to provide a comprehensive care and support. So, what is actually a multidisciplinary team? A multidisciplinary team for pain management, it's a group of healthcare professionals from different disciplines who work together to provide comprehensive care and support for individuals with pain. The team typically includes doctors, nurses, psychologists, physical therapists, occupational therapists, pharmacists, and other healthcare professionals as needed. Each team member brings their unique expertise and perspective to the management of pain. And they work collaboratively together to develop and implement a comprehensive pain management that is usually tailored to the individual's needs. The team may provide education, counseling, and support to the patient and their family as well, and also monitor and adjust the treatment plan as needed. Multidisciplinary pain management, it is mostly delivered in the outpatient settings, but of course, if resources permit, it can also be employed in the inpatient settings. While it is most often used for chronic non-cancer pain conditions, patients with other types of pain can also benefit from multidisciplinary pain management, if assessed as suitable, of course. The roots of developing a multidisciplinary team approach to the chronic pain management can actually be traced back in the late 20th century, when it became apparent that the traditional biomedical model of healthcare was inadequate for addressing chronic pain. The biomedical model, which focuses on treating physical symptoms and underlying pathologies, was unable to fully address the complex and multifaceted nature of chronic pain. So as a result, healthcare professionals began to actually recognize the importance of addressing the biopsychosocial aspects of chronic pain, including psychological and social factors that contribute to pain perception and its impact on daily life. So this led to the development of the biopsychosocial model of chronic pain. The biopsychosocial model was first conceptualized by George Engel in 1977. And it suggested that in order to understand the person's medical condition, it's important to take in consideration not just the biological factors, but also the psychological and social factors. Therefore, the biopsychosocial model for chronic pain highlighted the need for a more holistic and integrated approach to pain management, one that involved healthcare professionals from multiple disciplines working together as a team. Since we're talking about multidisciplinary teams, I would like to briefly mention about the very fine difference between a multidisciplinary and interdisciplinary team. So both multidisciplinary pain management and interdisciplinary pain management are approaches to treating chronic pain that involve collaboration between multiple healthcare professionals. In an MDT, members work together to develop a comprehensive treatment plan tailored to the individual needs of the patient. They work together to coordinate the care and ensure that the patient receives a holistic approach to the pain management. However, each team member may provide their own specific treatment modality. On the other hand, the interdisciplinary pain management, it's a more integrated approach with an emphasis on communication, collaboration, shared decision-making. All in all, to ensure that patient's treatment plan is comprehensive, it's cohesive, and effective. So overall, while both multidisciplinary and interdisciplinary pain management involve collaboration between the healthcare professionals, interdisciplinary pain management places greater emphasis on the integration and coordination among the team members to provide a more unified and effective approach to the pain management. So pelvic pain is a complex and intricate issue that can stem from various causes. And it is not uncommon for the patients to have multiple underlying conditions that contributes to their symptoms, which can in fact make their diagnosis and treatment a challenging task. The MDT approach is particularly important when it comes to managing complex conditions such as pelvic chronic pain, where the underlying causes and treatments may involve multiple specialties. So on this slide, we have a sum up of the importance of a multidisciplinary team and the role of multidisciplinary team. The MDTs are able to create a supportive environment, create a safe space, talk about the science of pain in common terms, provide peer support, support with pain flare-ups, or teach the patients about graded exposure and mindful medication administration. Another reason for which an MDT approach might be successful is the goal setting, teaching patients and helping them to explore what their goals might be. It can give them a sense of purpose, a sense of control, accomplishments, which in turn can help them to cope better with their pain. By involving multiple healthcare professionals, it ensures that patients receive the most appropriate care and effective treatment for their condition. So pelvic pain may be associated with coexisting conditions like anxiety, depression, or sleep disorders, and this can be addressed through an MDT approach, improving overall the quality of life for patients. I thought it would be fair to discuss briefly about integrative pain care, as it is 2023, the global year for integrative pain care. The International Association for the Study of Pain recognizes that pain management requires an integrative approach that involves multiple strategies to address the complex nature of pain. So an integrative approach to pain management involves using a variety of techniques and therapies to treat pain. And this approach takes into consideration the biological, psychological, and social factors that contribute to pain, and uses a combination of pharmacological and non-pharmacological interventions. Moreover, the IASP recommends a holistic approach to pain management that includes addressing the patient's social, cultural, and spiritual needs. It is also ideal to pursue a patient-centered approach care in the management of pain by involving the patient in decision-making and developing an individualized treatment plan based on their unique needs and preferences. Encouraging self-management by taking an active role in managing their pain can actually lead to improved pain outcomes. Many people who have had pain for a long time talk about having good days and bad days. They're talking about how much their pain gets in the way of the daily activities, and then how they may have tried to take advantage of a good day, for example, by using it as a catch-up day. So doing all the things they couldn't do on days when pain was overwhelming. As a result of overdoing on a catch-up day, they may have found that they've needed several days of rest to recover. That's why I find it very important to promote strategies for the self-management of pain. And here are a few examples that could work for patients to learn. The first one would be effective pacing. This means that the patient, rather than the pain, are in charge of how they plan, how they start, how they stop and change what they are doing. When a patient paces effectively, then they can also accomplish some more activities every day. Some examples of ways to pace activities include breaking up the tasks into smaller parts, take rest breaks in between the tasks, work at a slower or at a less intense pace, and gradually increase the amount of time spent doing a specific task. Also, changing tasks often and use different parts of the body throughout the day could be helpful. Another strategy of self-management of pain includes, obviously, a well-balanced diet, because the food we eat and the other substances that we consume can affect pain. Eating regular and nourishing high-fiber meals and drinking plenty of fluids are important to healing, managing pain, and staying well. Moving or exercising, participating in regular movements and exercise can actually improve the body's strength, flexibility, and endurance. And there may be times when it is necessary for the patients to lower their activity level because of the illness, or maybe because they need to recover from an acute painful injury. This is not really typically recommended for managing chronic pain, because repeated use of rest and avoidance of the movements can temporarily reduce pain, but they can lead to a decrease in strength, in flexibility, and endurance, and eventually they can increase the disability. Improving sleep. So a few suggestions on how to improve sleep would be to maybe set up the bedroom aside as a special place, so that their mind can associate this with sleep. Reduce activities such as watching TV before sleep, or maybe consider changing eating habits that may interfere with the sleep, like eating larger meals earlier in the day rather than a few hours before bedtime. Reduce or avoid actually caffeine intakes, soft drinks, energy drinks, or teas, as I said, especially within a few hours of bedtime. Reducing or avoiding alcohol, because alcohol can interfere with getting a deep and restful sleep, and also can interfere with the ability of staying asleep. Or considering to slow down before lying down, such as a warm bath could help, or reading something enjoyable, or listening to relaxing music. And another self-management strategy would be to encourage patients to shift focus. So what I tend to tell my patients is to pay just enough attention to the pain so that they can properly pace the activities and avoid doing any real harm. But otherwise, to look for examples in their life when their mind was so focused on something enjoyable that or so important that their pain actually receded a bit into the background. So yeah, using these examples to strengthen their understanding that pain is actually experienced more intensely when they actually pay attention to it, and it is less intensely when they engage their mind with other activities. I'd like to use a metaphor to explain how chronic pain feels for the patients. It's the stack of pillows metaphor. So a patient with chronic pain may feel, just imagine getting a bunch of pillows off your bed or off your couch or wherever. And one pillow, for example, might be pain. One pillow might be, I'm a caregiver. Another pillow could be, I have work commitments or have lots of shame or on top of this. So imagine stocking these pillows so high that we cannot actually see our way around them. And that becomes our only experience. So this is how the patients kind of feel. So how do they do? How do they get around that? What would be the answer here? So maybe the answer is actually to create some space between you and the pillows. And because by taking the pillows away completely might not be the solution to the problem. There are real things happening in the life, and the pain is real as well, with all the perks that comes together. So yeah, this is a metaphoric image actually. And I'm trying to express that removing this stack of pillows, removing the whole pain, it shouldn't be the ultimate goal in pain management, but actually creating some space for themselves by moving them a bit back should be the target, should be the targets that a patient should aim for. Because creating a little bit more space to do the things that are meaningful or to think about things or to notice things that come up in their life, yeah, it's mostly about accepting to have a life that might have pain in it, but it is not ruled by the pain. Now, going back to the role of the MDT, I would like to emphasize on how an MDT approach can actually improve chronic pain management. So imagine a patient, Sarah, 32-year-old teacher, who has been experiencing chronic pelvic pain for the past year. She has been to multiple healthcare providers, but has not found relief from her symptoms. She has had to take a leave of absence from her teaching job due to the pain and is anxious to return to work as soon as possible. Sarah's primary care physician referred her to a multidisciplinary pain management team, and the team consists of a pain specialist, a physical therapist, psychologist, and a nutritionist. So when she meets with the multidisciplinary team, they take a patient-centered approach and prioritize Sarah's goals and preferences. They ask her about her priorities, her values, what activities she enjoys doing, what goals she has for her treatment. So Sarah tells them that her top priority is to be able to return to work because her pain actually has been interfering with her job as a teacher. And the team takes this information into account and works with Sarah to develop a treatment plan that will actually address her pain and then enable her to return to work. So the treatment plan included a combination of medication, physiotherapy, cognitive behavioral therapy, and dietary changes. So a physiotherapist helped her develop a personalized exercise program that improves her strength, her flexibility, and mobility. She's also received education on pain management strategies like pacing and relaxation techniques. On the other hand, a psychologist addressed Sarah's emotional and psychological impact of chronic pain, reducing her anxiety. Then they developed coping strategies to manage stress and improve mood. And the nutritionist another important member of the MD team, worked with Sarah to develop a personalized dietary plan that included anti-inflammatory foods and supplements. So the MDT continued to monitor her progress and adjust her treatment plan as needed. And after several months of treatment, Sarah was able to return to work full-time and report a significant improvement in her quality of life. So this patient-centered approach ensures that Sarah is an active participant in her care and that the team is working together to achieve her goals. Living with chronic pelvic pain can be challenging and can affect many aspects of a person's life. So by addressing the various aspects of chronic pelvic pain, including the physical, emotional, and psychological factors, this approach can help patients become more functional and improve their mood, reduce the need for the long-term medication use. For example, as you can see on this slide, the problems tackled by the multidisciplinary pain management team are like disrupted activities of the daily living, inability to work, psychological distress, sexual dysfunction, urinary and bowel dysfunction, physical impairment, sleep disturbances, and as I mentioned earlier, unhelpful medication dependence. Research has shown that patients who participate in multidisciplinary pain management programs can actually experience a significant improvement in their daily lives and allows them to actually engage in activities that previously they could not. So how do we establish an effective multidisciplinary pain management team? MDTs rely on effective collaboration and communication between team members to achieve optimal patient outcomes. Discussions may center around how the team members can work together efficiently, how to share information effectively, and resolve the conflicts when they arise. Patient-centered care is actually the cornerstone of the MDT approach. The patient's needs, preferences, and values should be at the center of the decision-making process. And the team should prioritize the patient's goals and adjust the treatment plan as needed. Each member of the MD team has a unique role and contributes specific skills. For example, a physiotherapist may focus on improving the patient's mobility and reducing the muscle tensions, while a psychologist may focus on addressing the emotional and psychological impact of chronic pain. The team should clarify each member's role to ensure that they are working together effectively. Sometimes MDTs may face challenges such as communication breakdowns, maybe role ambiguity, and resistance to change. And discussions may focus on identifying these challenges and developing strategies to overcome them. Of course, training and education are also essential for effective teamwork. The team should ensure that all members receive the appropriate training and education to work together effectively. Regular evaluation and feedback are important for continuous improvement. The team should establish a culture of feedback actually and encourage open communication. And use objective measures to evaluate the patient's outcomes. Establishing a shared vision can actually help build team morale and the motivation. So the team should develop a shared vision for improving patients' outcomes and celebrate successes. Chronic pelvic pain patients, they often see multiple healthcare providers. So it's important to remember that sometimes this can lead to fragmentation and maybe confusion in their care. And that's why a multidisciplinary team can provide a coordinated care and while the team members communicate with each other and work together to ensure that the patient receives the best possible care. And so overall, chronic pelvic pain can have a significant impact on patients' quality of life and well-being. So it's important for healthcare providers to address not only the physical symptoms of the condition, but also the emotional, the social, and the economic difficulties that patients may face. And a multidisciplinary approach to chronic pelvic pain in pelvic pain management, it is important because it recognizes that pelvic pain can have multiple underlying causes. which will probably require an input from various medical specialties to diagnose, and treat effectively. And this is me.
Thanks, Andrea, for your presentation. We'll take questions from anyone. If you want to ask any question to Andrea, you can just type in and we'll ask her questions. Looks like, Andrea, there are no questions for you.
No problem.
So anybody has any question for Ashish? Ash is still here. I think Ash has answered most of the questions. Yeah. Okay, so a question coming from Nofil. So Andrea, thanks for the great talk. Do you do male pelvic pain treatment too? Sorry, you are mute.
Oh, I'm so sorry about that. So I was saying no, unfortunately not, because I'm working now with the endometriosis team. So yeah, we mostly see female patients with chronic pelvic pain.
Sure. So there are a few questions now coming now. What is the evidence for CBT and biofeedback in terms of managing pelvic pain? So evidence of CBT and biofeedback.
Yeah. I mean, there is a lot of evidence of CBT, although I think this is more of an old approach, because I believe nowadays we're focusing more on ACT approach, commitment therapy, acceptance and commitment therapy, more than CBT approaches. But yeah, I believe, I guess it depends on what it is applicable to each patient, what works for them. Sometimes might work, sometimes might not work.
Okay. So there is another question from Almas. How do you develop subspecialty interest? Physiotherapist is asking from IMIC perspective.
Sorry, can you repeat that? How do I double up?
How do you develop subspecialty interest physiotherapist, asking from IMIC perspective? So it's a subspecialty physiotherapist. It's like pelvic physiotherapist. How do you develop those interests instead of general physiotherapy?
I'm sorry, this question is not very clear to me, but I can say that physiotherapy is an important part for managing chronic pelvic pain. And how do you double up? Maybe you can rephrase the question.
That's fine. Okay, don't worry. So there is another question: do you offer TENS or acupuncture as a nurse-led service for these patients? And if so, what are your outcomes overall? It's from Becky.
Okay, personally, I don't deliver acupuncture, but I know that acupuncture, it is used by different pain clinics where the nurses can actually deliver the acupuncture. And again, I believe it's about the patients and their preferences. Sometimes acupuncture can be very effective for them in managing the chronic pain, but some other times they might try without any effect. I would strongly encourage, actually, if you have an interest in delivering a nurse-led acupuncture clinic for chronic pelvic pain patients, it's something that is worth trying and initiating for this category of patients.
Okay. There's another question from Rebecca that I work in an Oxford pelvic pain clinic. They see a lot of patients with trauma histories and offer specialist trauma therapy. Is it something you offer in your clinic?
So indeed, many patients with chronic pelvic pain will have some traumas on a background, and usually it's ideal to offer them some like a review from a psychologist, or at least to open the conversation with them regarding this. and make them be more open to the idea of seeing a psychologist, because it's good. The best therapy in the end is to actually to have someone to talk about these underlying issues that can actually add to the condition of chronic pain. So in my service, to answer to your question, yes, we see patients that they do need referral to a psychologist, a pain psychologist. So yeah, we will refer them to this kind of specialty. I think it's very important. Yeah, it's a very important it's a very important thing in the patient's care in order to manage their pain.
Sure. And how does the patient get referred to you from the pain clinic?
So in the endometriosis service where I work, it's actually the endometriosis consultant that sees the patients, and then they involve us in their care on a needed basis. So if it's a more complex patient with chronic history of opioid use, for example, or chronic pain over several years, then they automatically engage us in this patient's care. So it's not like, so in the service where I'm, as I said, we focus on the endometriosis patients, and yeah, their chronic pain, pelvic pain. It's not like we receive referrals from outside. I mean, it would be obviously the consultant receiving the referral, and then we automatically get involved into the patient's care.
Okay. So another question I think which is quite relevant to your talk is about cultural barriers in chronic pelvic pain, particularly for Southeast Asian population. How do you overcome these cultural barriers? Any tips on that?
Yeah, the short answer is that actually there is no short answer here, but it's difficult, and there is not always you can work on these cultural barriers. But I guess what helps in general is to be open to the patients, discuss with them, present them the facts, and encourage them that they are not the only ones. And sometimes maybe organizing a peer support group where they can hear the stories from other people that have been through similar pain aspects. Yeah, sometimes can help, and they can be more open to conversation. Yeah.
Sure. Thanks, Andrea, for your presentation. And we'll take any questions for Ashish. If there's any question for Ash, Professor Ash is back. So. Okay, so there is another question from one of our anonymous attendee. Congrats to the speaker organizer. Do we get a CPD certificate or attendance certificate? Yes, we can arrange an attendance certificate. I will ask the British Pain Society, the SIG group, to give an attendance certificate to all attendees, and we can send it through email. Any other questions? If there are none, then we will stop the recording and the webinar. Esther, can you come? Sorry, it looks like they're okay. Ocean, okay. So is the recording being sent? We have recorded it, but I'll have to ask the BPS to whether it can be sent to the attendees or not. So thank you. Thanks a lot. And we would like your feedback, all of you who have attended the webinar. That will be good for us so that we can, whatever mistakes we have done in this one is not repeated on the next one, and we can do better. Thanks everyone for your help.
Thank you. Bye-bye.
Thanks.
Thank you.
Thanks, Ash.
Thank you.
Thanks, Andrea.
Bye-bye.
Hi, Esther, sorry. Can you